My name is Jeremy Kortmansky. I am a medical oncologist here at Smilow with a focus in GI oncology. I wanted to thank everybody for joining us on what I hope is the last gasps of winter before spring comes. But March is an important month, especially for those of us who care for patients with GI cancers, as it is Colorectal Cancer Awareness Month. And so we have a really important educational program today, co-sponsored with the Colon Cancer Foundation. And so I wanted to, before we get even started, introduce Cindy Barassi to get us going.
Thank you, Dr. Kortmansky. I really appreciate it. And I just want to welcome everyone and say, first off, thank you to the Smilow Center for having us. And I want to say happy March, happy Colorectal Cancer Awareness Month. It's a really special month for us here at the Colon Cancer Foundation. We are dedicated to a world without colon cancer, colorectal cancer. Again, my name is Cindy Barassi. I'm the president of the Colon Cancer Foundation. I also serve as a steering committee member on C5, which is the New York citywide Colon Cancer Control Coalition. I serve on the New York State Cancer Consortium as a colon cancer action team member, and I serve on the Family Health History and Early Age Colorectal Cancer Task Force at the National Colorectal Cancer level. So quite involved in colon cancer, as all of you are. I'm going to share a few slides, not take up too much of your time tonight, so bear with me as I put those on. There we go. Okay. So we just went through all of that. So the Colon Cancer Foundation, first off, can you guys see that? Just if you could nod for me, that would be great. Perfect. We've been around for 19 years. We were founded by a surgical oncologist. His name was Dr. Thomas K. Weber. We unfortunately lost him, ironically, to another form of cancer a couple of years ago. But he, as all of you are, was quite passionate about the disease and seeing too many patients walk into his office with a late stage of colon cancer. So he actually founded one of the nation's first walks and runs to raise awareness of the disease in the New York metro area called the Colon Cancer Challenge. And we're actually having the 19th version of that walk and run at the end of this month, March 27th in Queens, Flushing Meadows. So we would love for all of you to join us at that event. So we have three prongs to our mission: prevention, advocacy, and research. And under prevention, we focus primarily on education and awareness. And under education, we focus heavily on patients and caregivers. And then we also focus on educating clinicians. And we're beefing that section of our website and materials up. And when I say clinicians, we've really focused over the last 8 years on educating clinicians about the rapid rise of early age onset colorectal cancer, which we'll probably dig into later on this call. If not, circle back and I'll tell you some more about that myself. But it's a trend that we've been seeing, unfortunately, grow over the last decade. Second prong of our mission is advocacy. And we advocate for quality of life, fertility preserving treatment for all patients, regardless of where they're treated, whether they're treated here at Yale in New Haven, or whether they're treated in a community cancer center, anywhere else in the country or around the world for that matter. We advocate for equal opportunity access to testing and screening, as well as treatment for all patients. And then also for assistance for caregivers, because that assistance needs to continue throughout the patient's and the caregiver's entire continuum of care, we call it, even through end of life. And we do a large portion of that through our own event called the Early Age Onset Colorectal Cancer Summit, which we're now going into our 9th year. And that focuses largely again on the fact that this is affecting younger and younger men and women throughout the world. And then finally, the last prong of our mission is research. We focus on primarily supporting young investigators who travel to conferences around the globe and support their efforts in moving the ball forward in translational research. see if I can move my, okay. So for 2022, just very briefly, we have some big, hairy, audacious goals, or BHAGs as we like to call them. We want to raise enough money to essentially provide 10,000 free screening test kits in underserved and underinsured communities throughout the nation. And we want to be able to tell 21 million Americans ages 45 to 49 that 45 is the new 50. And one of the ways that we're doing that is through our major campaign called letsgetscreened.org. So if you actually visit that website, it is live. We started that campaign with Walgreens last year, and we're continuing that. So we invite you to go to letsgetscreened.org. There are materials there. There are social media kits there, and we would love for you to be a part of that and just spread the word. And with that, I will turn it back over to Dr. Kortmansky, and I look forward to hearing everything everyone has to say tonight. Thank you.
All right, thank you, Cindy. I think nobody can oversell the importance of colonoscopies. And so I hope during our program tonight, we brought together a lot of experts on diagnosis and treatment, but with colonoscopies, this could be a preventable disease, which is the hope for all of us. In the treatment of colon cancer, we know that it is a disease that takes a team. It takes gastroenterologists and surgeons and radiation oncologists and medical oncologists all working together. And so we designed a program tonight that does just that. And so we have Hamita, Sachar from gastroenterology to give us words about screening and some syndromes, the newest advances in surgical management with Dr. Mongiu and Dr. Amit Khanna, advances in radiation oncology with Dr. Kevin Du, and then taking us home, advances in medical oncology with Dr. Justin Persico. And so with that, I'd like to turn the baton over to Dr. Sachar.
Thank you, Jeremy. I'm just going to share my slides. Okay, so I'm going to be talking today about about colorectal cancer screening and sort of some of the updates that were provided in the new USPSTF recommendations that were given in 2021. So colon cancer is important. It's the third leading cause of cancer death in the United States, only lagging behind lung cancer, breast, and prostate cancer. In 2021 alone, approximately 53,000 people were estimated to pass away from this disease. So the important takeaway point from all of this is that this cancer can be prevented, or it can be detected fairly early, such that no one should have to die from it. This schematic that I have down over here primarily is just trying to show what the natural history of colon cancer would be like without any sort of intervention that's made by screening. So you sort of start out with not having any sort of a lesion, and then you eventually grow something called a polyp, or what we call a precancerous lesion, or an adenoma. And eventually that, if not intervened upon, that could potentially become an undiagnosed cancer. So that would basically mean you would not yet exhibit any symptoms from this cancer, but it's in there. And eventually that will become something that would cause symptoms. So things like rectal bleeding, change in your bowel habits, weight loss, that kind of stuff. And again, if not intervened upon, it can result in colorectal cancer death. So the point here is that screening effects can mimic sort of the biological cycle of this cancer, and sort of interventions can be made early. So they can either be made in this stage, which is at the adenoma stage, and it can really, by doing so, you can really prevent cancer from forming, or you could really intervene at this stage, which is essentially the preclinical stage. And by doing so, hopefully we found this cancer at a more treatable stage. So the incidence and mortality of colorectal cancer in the United States has decreased over the past decade, about 30% or so. And screening is very clearly a very important contributor to this. So based on all of this, the USPSTF gives a grade A recommendation for screening, and it says that the net benefit is substantial for patients if they get screened for colorectal cancer. So some other facts that are interesting is that even though this has been highly recommended, the national adherence to screening is not perfect. So approximately 26% of patients who are eligible for screening don't actually get screened. And as of 2018, about 31% of patients have not kept up to date with their screening. Now, there's many factors that probably affect these estimates essentially, and ultimately probably provide barriers to screening. And we all know that they're sort of exacerbated in minorities and underserved populations, but there are issues related to access and how patients utilize these tests that have substantial effect on whether they get screened or not. Financial barriers are real, and luckily there has been a lot of movement in this such that they have been removed or mostly removed for patients so that they really can access screening. Ultimately, if your recommendation comes from your own doctor, it carries a lot of weight, and if there's some informed choices made alongside, it really can affect our rates of screening. So a few things. What do you need to know if you want to be screened? There's a few things related to your risk level, what your own history is, something about age, a little bit about what your kind of medical conditions you have, and what your preference is. So when it comes to risk, we like to sort of divide patients up and say your average risk, basically, if you have no signs of symptoms suggestive of colorectal cancer. So basically no rectal bleeding, no pain in the belly, no change in your bowel habits. And if you basically don't have any of the risk factors that I'm going to just sort of talk about real quick. So if you're increased risk, we really think that that's the kind of patient that has a first-degree relative with colorectal cancer or basically high-risk polyps. If you have two second-degree relatives with the same, you would be considered at increased risk. And if you had a personal history of colon cancer or polyps, that would also be considered to be an increased risk patient. A high-risk patient is anyone who has ulcerative colitis or Crohn's disease. And this is simply related to the fact that chronic inflammation can give rise to colon cancer. And the highest risk patients are those who have confirmed or suspected genetic syndromes, such as FAP or Lynch syndrome. There's many others, but Lynch syndrome is probably the most common one that's inherited. I just wanted to mention that most colorectal cancer is not inherited cancers. It's quite a small percentage overall, but when you do have one of these inherited syndromes, it's pretty important that we look at you fairly carefully and follow you very closely. So what tests are available for screening? The answer is a lot. All right, so there's about 7 tests that are available for screening. And while this is great, it's also fairly confusing for patients to figure out what test they should use. So the bottom line here is that while there's multiple tests, they all have varying evidence that support their effectiveness. And there's really no head-to-head trial that suggests one test is better than the other, but they all have advantages and disadvantages. Now, ultimately, the USPSDF has not ranked any of these tests. So the bottom line here is the goal is to get screened. So any test is better than no test. And ultimately, whichever test you're going to do is the one that's best for you. All right, so just a little bit about some of the tests that we'll be talking about. The first one, actually, I just want to go back. Sorry about that. All right, so the very first group of tests that I want to talk about is something called stool-based tests. So they sort of come, there's 3 of them that you should probably know about, but ultimately the important thing to know here is that they need to be done every year or every 3 years. And I'll go over each one just to see which one is easiest for the patient to do. But in order to derive benefit from these tests, one needs to do them year after year in order for them to be effective. So in terms of the FOBT, which is a very common test that people used to do, and often at the office, although it's contrary to popular belief, it's really not an office-based test, you really do have to submit 3 separate samples, and you have to have some sort of dietary restriction in order to prevent a false positive for this test. But it's an old test, it's a little bit out of vogue, but it has been shown to be fairly effective in decreasing colorectal cancer related mortality. You don't need a bowel prep or any sort of sedation for this. It's fairly easy to use and inexpensive. The other test that most people may have heard about is something called the FIT test, which is a fecal immunohistochemical test. It's basically detecting intact human hemoglobin in stool, and it's very easy to use. You really just only have to submit a single specimen. It's pretty inexpensive as well. Now, some people may have heard about something called the ColaGuard, which is a FIT DNA test. And what it does is it takes the FIT test, which is looking at the human hemoglobin, and it combines it with another test that looks for altered DNA biomarkers in cells that are shed in stool. It's probably more sensitive than the FIT test in itself in detecting colon cancer if it's used for every one test that you do, but it also gives rise to a lot of false positives. And every time there is a false positive, it results in another test, often a colonoscopy. And so that is something to keep in mind as well. It is a single sample test, but usually you have to submit an entire bowel movement for this, and it does not require bowel prep or sedation. It is fairly expensive though. The other set of tests that are used are something called visualization tests. So, you have the stool-based tests, and they do all kinds of things to see if there's any sort of markers for colon cancer. But these are visual tests. We're really looking with our eyes to see if there's anything wrong or anything that we can intervene on. So the first one that I'll talk about is called a CT colonography. As the name sort of suggests, it's sort of a CT scan of a patient. And what they're really doing is they're looking inside the colon of a patient where they pump a little bit of air, and they look for either cancer or really some polyps or adenomas, which are precursor lesions for colon cancer. So this test does require a bowel prep, but it doesn't require any anesthesia. And one of the disadvantages or advantages, whichever way you want to look at this, is that you can sometimes find things that you may or may not want to know about. So sometimes it's useful if you find something that's not that could be life-threatening, like an aneurysm or something like that. But sometimes you find things that you really don't probably need to intervene on and probably needs to unnecessary testing. There is this concern about radiation exposure as well, but it's really related to repeated exams, if anything. So typically what will happen is this is your colon, and see there's a polyp in here. One would insert a rubber tube and put some air in there so that this could be clearly seen when the patient goes through a CAT scanner. Now, colonoscopy. This is far and away the most popular test in the United States. And what it really involves is this flexible tube with a camera at the end of it to be inserted through your rectum, and it kind of goes all the way through your colon. And this picture kind of shows what a normal colon looks like. A very careful withdrawal is done, in which all the parts of your colon are looked at carefully. And if there was a growth like a polyp, the good thing about this test is that we're able to intervene right then and there and sort of remove this polyp. You can see sort of a lasso being put around this polyp so that it can be transected. So in some ways, while this looks for cancer and it's a screening test, it also prevents cancer by removing precursor lesions. And sometimes it can also be used to remove early cancers, and it prevents the need for surgery. So again, colonoscopy is probably the only test that really helps with prevention as well as early detection. And it is associated with less frequent screening intervals. It's somewhere in the order of 10 years if you really don't have anything in your colon that requires follow-up. Although it does require bowel preparation, there's some sedation involved and inconveniences like being transported to and forth from the endo unit. The last one is something called the flexible sigmoidoscopy, which basically is just evaluating the left side of the colon. And modeling suggests that it's probably less beneficial if used alone when compared to the other screening strategies, except if you combine it with a FIT test, which has to be done every year. And ultimately, this test is just a little less popular in the United States and probably not used as frequently as colonoscopies and other stool-based tests are. I just wanted to show everyone what it means to sort of screen and what benefit this really has. So this really shows us how many life years are gained if one is to engage in any sort of screening strategy. So this kind of lists all the different tests that you can do, and this kind of shows how well it performs for patients. So this is life years gained per 1,000 patients who are screened, and you can see that more or less they perform the same. This is about how many cancer deaths averted per 1,000 patients who are screened. And then this kind of shows harms. And obviously the harms are mostly related to a colonoscopy because that's pretty much the only one that involves a procedure. And any sort of harm that's associated with a stool-based test is usually when they turn positive and they end up having to require colonoscopy. But relatively speaking, if you look at the numbers of how many years, how many deaths you avert versus how many patients you cause harm for, is fairly small. So the question here is, for an average risk patient, when do you start and when do you stop screening? So it's fairly clear from all the evidence that's available over the years that if you're between ages of 50 and 75, there's a clear reduction in death related to colon cancer if you're screened. If you're over age 75, though, this benefit is declined. It's not terribly declined, but it's really probably not as useful as when you're between 50 to 75. I do want to emphasize that if you've not been screened before, it's probably best applicable to you. So if you have had colonoscopies age 50, age 60, and then again at 70, it probably is not very beneficial to keep doing it from there on forward. However, if you've never had any sort of test before, this is probably a worthwhile test to engage in, provided you're in good health. And then for age 86 and over, it's a pretty clear no, because the benefit is very minimal at that point. Presumably you have other diseases that may be taking center stage in your life at that point. Now, some of the harms that we need to talk about, because whenever we think about screening, we think about risks and then we think about benefits. So we just talked about the benefits part, but what are the risks really? Like I mentioned before, they're largely related to the colonoscopy. And it's either when you do the primary exam or when you follow up a stool-based test or another test that shows a positive finding. And what we know is that if you're between age 50 and 75, the risk is rather small. And as you keep aging, the risk, while it's small to moderate, it does increase ultimately. So this is ultimately what the USPSTF said as of 2016. They were like, for everybody 50 to 75, go ahead and screen them. For 76 to 85, be selective. How about discuss with your doctor and decide whether this is worthwhile? And then if you're 86 and over, the idea is not to screen. It's a grade D recommendation. So between 2016 and 2021, really, the question that was raised was whether we should screen earlier than age 50. And this basically came about because we realized that colon cancer incidence and mortality was decreasing for patients who were 50 and over, but it was increasing for patients who were less than 50. And really where it was most substantial was in the age group between 40 to 49. Why this increase occurred, I'm not sure we can fully answer this. I mean, whether it's related to your diet or like body habitus, smoking status, it's not entirely clear what has led up to this sort of trend. But ultimately, after all the information was collated, initially started with the American Cancer Society, but eventually with the USPSDF, it has been made fairly clear that for patients who are age 45 to 49, we should be screening them using the same strategies that I just mentioned. And while this is a grade B recommendation, still a pretty solid recommendation to carry forward. Now, how did they come to this conclusion? I won't burden anybody with this, but ultimately it's because they updated the predictive modeling that is involved in trying to come up with these recommendations. It's also clear that if you save patients at age 45 forward, there's a lot of years that you're saving for this patient in their lifetime. So it really does have a huge benefit to that patient. So we do know that if you're younger, you have a heavy burden of disease. And we do know that this rise that's occurring in colorectal cancer is not artifactual, it's actually real. And so if you start screening at 45, hopefully you will benefit all those patients who are between age 50 and 54, because we all know that nobody usually starts right at 50 on the dot. So it gives them a little bit of leeway to make sure that they come on time. And then we already know that certain populations were already suggested to start a little bit early, like the African Americans in particular. So this age starting at 45 encompasses nearly everybody at this point. So according to the American Cancer Society and the USPSDF, we have a green light to go ahead and start screening at age 45. Now, this just sort of, I just wanted to sort of talk a little bit about patients who may not be as well as somebody who comes into your office and say they have a pretty devastating disease like cirrhosis, in which they're not doing very well. And then the question here would be, would you screen this patient, and would one recommend that? The question really is, the answer here is not really. So if you have a life expectancy less than 5 years, it's probably not worthwhile to undergo screening. So that just comes with a small caveat there. While we encourage everybody to get screened, it really should be an individual decision if these sorts of things are at play. I just wanted to mention that patients who are at increased risk, which we defined as, your family history for colon cancer, how do we screen these patients? So like I mentioned, if you have a first-degree relative who has an age that's over 60, you can really use any screening modality, but you must start at age 40. And you would follow the intervals as per whatever your test, each test suggests to do. So for a FIT, it would be every year. For colonoscopy, 10 years, depends on what the findings are. If you have 2 second-degree relatives, you sort of follow the same thing again. But if you have a first-degree relative whose age is less than 60, really the only test recommended here is a colonoscopy. And it's just because you're considered to be at truly high risk. And you probably should start at age 40 or 10 years before the youngest case was diagnosed in your family. And you should be repeating this test every 5 years. Just to define what a first-degree relative is, that's your mom, your dad, your brother, your sister, your kids. Your second degree is grandma, grandpa, cousins, aunts, that kind of stuff. Now, what do you do with patients who are high and highest risk? Well, these are the patients who have genetic syndromes and or inflammatory bowel disease. And really the answer probably here is they should probably be going to a center that has experience with managing these patients because they're probably best served in these sorts of institutions. So in summary, the mortality from colon cancer can be prevented. There's not enough patients who are getting screened currently. There are many strategies that are available, and the goal ultimately is to screen them by any method that they prefer. So any test is better than no test. And colonoscopy does carry that extra benefit of being preventative as well as trying to find early cancer. And that's what I have for you today.
Thank you so much, Hamita. That was a great presentation, really emphasizing all the different options that are available to get the colon cancer screening done. To not seeing any questions in the chat and to try to keep us on a reasonable schedule, we'll move on to the next talks, which is a combined effort between Dr. Ann Mongiu and Dr. Amit Khanna. So Dr. Mongiu, we'll let you start.
All right, let me go ahead and share my screen. All right, hi, good evening. My name's Ann Manchu, and I'm an assistant professor of surgery at Yale New Haven Hospital, and I specialize in colon and rectal surgery. And tonight, myself along with Dr. Khanna are going to speak to you briefly about some advances and innovations in the surgical management of colon and rectal cancer. I like to work with pictures. So the first thing people ask about when they are diagnosed with a new colorectal cancer is about what surgery are we going to do? How much colon are we going to take out? And how are we going to actually do it? So to answer that question sort of requires knowing maybe where the cancer is. And then additionally, as we just talked about, maybe if there's an underlying genetic disorder that might actually put the entire colon at risk, we may not just take one portion of the colon with the cancer, but we may have to take more to prevent the risk of future cancers. And so here we see that the surgery to remove colon cancer has a bunch of different names, and those are names that the specialist might say, but those just really mean that we're going to take out the portion of your colon that actually contains the lesion. And in doing so, we want to take good healthy colon on both sides of it. We also take the blood vessels that supply that part of the colon, and with that comes the fat and all of the lymph nodes. That combination of tissue basically allows the pathologist to really get all the detailed information that they need to know about what your tumor was, if it has spread anywhere else into the lymph nodes, and allow us to know that we've gotten everything out cleanly. And so how much we take out in the operating room really depends on the exact location and what blood vessel territory is serving that portion of the colon. And these are just some illustrations. Historically, when we think about surgery, we think about what we call traditional open surgery. That's surgery whereby we go to the operating room, we make a vertical up and down incision in your abdomen. We open the abdomen, we take out the area that we need to take out. We put the two ends of the colon back together, and then we close the abdomen with either stitches or sometimes you may have seen surgical staples. It's very effective, but the recovery from that can be a little bit painful because you do have a large incision that runs up and down the middle of your abdomen. And also there's a risk of forming a hernia afterwards, and the pain can often slow people's return back to their normal activities and ways of life. So moving on, in the early to mid 1980s, the field of general surgery, from which colorectal surgery is a part, started taking cues from our colleagues in the fields of urology and gynecology, which had started this new keyhole or minimally invasive surgery. We refer to that now more often as laparoscopic surgery. Laparoscopic surgery allows us to make small incisions in the abdomen, put some gas into the abdomen. We usually use carbon dioxide, blow it up, and then use a very tiny, precise camera, as well as long instruments, which are on a straight stick. And we can now do that same surgery that we had to perform previously through a large incision through a bunch of small incisions, which are about the size of my thumbnail or a little less than a centimeter. Usually to make that connection, we would still have to make a small incision in the middle of the abdomen to pull out the intestine, put the two ends back together, and take out that last portion once we'd freed it up. But this is really a really much smaller incision. People started to use this first for gallbladder surgery and then for appendix surgery. And eventually the field of colon and rectal surgery moved heavily into minimally invasive surgery. And this really sort of revolutionized people's recovery from having a portion of their colon removed. Just like our iPhones continue to get more and more advanced with each iteration, surgery continues to advance. And you may have seen ads or pictures about robotic surgery. And so robotic surgery is really just a further refinement of laparoscopic surgery. The robot doesn't actually do any operating on its own, but what we see here on the left-hand side of the screen is the Da Vinci intuitive surgical robot. And what it does is it actually holds the instruments. And in doing so, you have now 4 operative arms for a single surgeon, whereas if I go back to the prior slide, you can see that each surgeon, we've got 2 hands. At most, you could hold 2 instruments, or you could hold a camera and an instrument. So one person, you really need 2 people in any operation to do a colon operation. Now, when we talk about the surgical robot, there's actually 4 arms and a single surgeon controls them. The way the surgeon controls the robot is you actually go about 10 feet away from the patient in the operating room, and you sit down at this surgical console that you see here on the right-hand side of the screen. The console is sort of very ergonomic and adjusts to each surgeon and saves it, just like your car might save your seat positions when you get in. And when you sit down, you're looking into this console that you see here on the right. It's actually a pair of goggles that you look into. And now you have a 10x magnification of your operating field. And not only that, it's in 3 dimensions because the camera that the robot uses actually has 2 parallel cameras in line with each other. So that gives you what we call a depth of field, or allows you to see in what looks like 3 dimensions without actually wearing any three-dimensional goggles. The view is incredibly sharp and incredibly bright. So that's one advantage here, is that we now have an incredibly stable platform that doesn't have any rotation, or because you're not dealing with a human holding instrument, you're dealing with a very precise robot. The second thing that's really neat are the actual instruments. These instruments that the robot is holding, they are actually far more advanced than even our most advanced current laparoscopic instruments. And the reason for that is that they have wrists just like a human hand. And so they can actually articulate with more degrees of freedom than the human hand actually can. This allows them to get into very small places. And also you can manually scale how precise the movement is. So that you can actually make very tiny, very precise movements in very tight areas. And this allows us to do things like very carefully peel tumors off of large blood vessels, something that might have required, that might have been a little bit more tedious in a laparoscopic situation, somewhere where we have much better control because of our superior visualization. This is particularly helpful when we talk about rectal cancer surgery, because the ability to go deep into the pelvis to find low rectal cancer tumors and actually spare your sphincter complex, which is, means that we can eventually render you without any sort of colostomy bag, is a wonderful thing. Previously, low rectal cancers, a lot of people ended up with a permanent colostomy bag. Because of robotic surgery and our ability to get very low into the pelvis, we're actually able to restore people to complete continence much more regularly now. And that's, I think, one of the huge benefits of this. A third benefit is really in a small detail, but it's the fact that we're actually able to put the two ends of the colon back together inside of your body without having to pull anything out. And why that is good and useful is that then allows us to take out the part of the colon that had the cancer through an incision, like a low C-section incision, or what we call a fan and steel incision that's actually in the bikini area. This is not only good from a cosmetic standpoint, but it's really good because these incisions are much less painful. People recover from them much more quickly, and they have a much lower risk of hernia formation. The next two slides I'm going to show you are just one other really neat feature, a safety feature of the robot. That's something that's great, that has really also adjusting the way we think about certain parts of robotic colorectal surgery. In the 1950s, a fluorescent dye called indocyanine green was identified. And it was actually used in some cardiac studies. It's a non-toxic dye that fluoresces green when exposed to infrared wavelengths of light. And so intuitive thinking that this was the surgical company think that this was actually could be a very useful dye and was being used in different areas of surgery as people were starting to look at perfusion. This dye lights up blood vessels, actually incorporated infrared technology into the robotic camera so that with the touch of your finger, you can actually toggle the screen that you look at in your headpiece to see this infrared view. So this actually comes in handy in two really critical parts of colon and rectal surgery operation. So I'm going to tell you a little bit about this picture we see here. On the right-hand side of the screen, we see the colon and one of our operating instruments here on the right. And the colon is, we're looking at where are we going to divide it to make our division point to take out the part with the cancer. The part with the cancer is off to the right-hand side of the screen. We don't see the marking. It's a little further off. If we're looking here at the screen itself, right beyond the tip of the instrument, we'll see maybe there's a faint difference in the color of the colon. Maybe it's not quite as pink as the colon is right here. But, we would be looking at it to try to decide, is this area, because we've already taken the blood supply to this part of the colon, and we want to make a healthy connection between the two remaining parts of the colon once we take out the part with the tumor. So when we inject the dye and we flip to our infrared imaging, it actually glows bright green. And so right here, you can see a line where the colon is very, very green. All the tissues are candy apple green. And on the other side of it, it's very dim. And this actually allows us to very safely and accurately divide the colon inside the body with our surgical staplers and know that we are dividing at a point which is very healthy. And it's going to help us to put the two ends back together in a safe way. One other way that we use it, and this is just a brief one, again, on the right-hand side is the view that the surgeon would see if you were doing open or laparoscopic surgery. And on the left-hand view, we see a structure that's highlighted in green here that you can't really even appreciate at all on the right-hand side of the screen. This little tube that's been lit up here on the left-hand side of the screen is actually the ureter. That's a little tiny straw-like structure that connects your kidneys, which make urine, down to your bladder. Well, the ureter runs underneath the colon. And so it's often in the field of our operations, especially if someone's had radiation treatment or has had prior abdominal surgeries, it can get pulled into our operative field. And that's something that we'd like to avoid. So we're actually able to inject the ureter with this fluorescent dye, and it stays and glows bright green throughout our entire operation, sort of like, I call it like a landing strip at the airport, and shows us, hey, this is down here, and it allows us to not to have to even expose it. We can actually just push it down with its normal tissue layers of covering. Normally in the past, we would have to actually dissect out the ureter to make sure we had it before we fired any staples. Now we can actually see it through tissue and know that it's safe and secured and out of our way. So those are some of the advances in actual technical side of surgery. And Dr. Khanna is going to go on in a minute, talk more about our care pathways. But something I want to talk about briefly that you might have heard of is enhanced recovery after surgery. So we've made surgery less invasive, but how can we get people home more quickly and get people back to baseline sooner after you've had a colon surgery? And so the pathway that involves everyone from our preoperative team in the clinic to our anesthesia colleagues and nurses in the operating room, as well as the surgeons, as well as our nurses on the floor after surgery, is what this ERS pathway. And what it is the goal is to set your body back to its normal status as quickly as possible. One of the ways we do this is by letting people drink clear liquids all the way up almost into the time of surgery. Before we said you'd have to fast for hours and hours before surgery. Now we know that you can actually drink high carbohydrate drinks even 4 hours before surgery, which means your body has less stress when you're in the operating room. By having less stress in the operating room, your body is actually able to start bowel function back up sooner after surgery. When we're in the operating room, we now work with our anesthesia colleagues. They work on multimodality pain control, which means we try to avoid opiate pain medication, both in the operating room and afterwards. By minimizing opiates, the intestines wake up faster from surgery. And when they wake up faster, we get you out of the hospital faster. And so our colleagues in the operating room use less opiates, and they also minimize the amount of fluids. And then we get to after surgery, and what we like to do is we start you eating right away. Sometimes people still come and say, oh, so I'm not going to be eating for several days. I'm like, no, you're going to start drinking liquids a few hours after surgery. We like to stimulate the GI tract again to function. We like to take out excess IVs and drains as soon as we can after surgery. We like to take the Foley out, you know, if not the night of, the morning after most surgeries, so that people get on their feet more quickly. We have nurses that are ready to help patients walk in the halls of the hospital after surgery, even sit in a chair the night of surgery. All of these things serve to bring our body's systems back to normal more quickly. And the sooner the body feels like we're back to normal, the sooner that we feel back to normal and have return of function and get back home and get back on with living our lives. So it's just a little bit about more of the mechanical side. And now I'm going to turn it over to my colleague, Dr. Khanna, to talk to you about some of the bigger picture sides of how we integrate within the system. Just stop sharing. All right.
All right. Dr. Khanna, do you want to go right to your talk, and then we can address any questions?
That'd be great.
Maybe after that.
Sure. I'm going to try to share my screen here. Let's see if we can get this to work. Okey-doke. All right, I hope everybody can see that. Nod will help me know that everybody can see the screen there. You guys seeing? Great. My name is Amit Khanna. I'm one of the colorectal surgeons at Yale. I'm mainly based out of the Bridgeport Fairfield region, and really a pleasure to be here with everyone tonight. And thanks so much to everyone for coming online for a talk about colorectal cancer. So I think Dr. Mongiu did an incredible job of showing some of the incredible innovations that we have in colorectal cancer surgery today. What we can do now is use robots, as Anne pointed out, and now our hands are attached to robots, and we guide robots with precision in a way that we really couldn't do years ago. And I think Dr. Mongiu did a great job of that. And so, this is just the tip of what we're doing in terms of technology and how technology has really changed the way our patients recover and the outcomes that we get for our patients for colorectal cancer surgery. And what we see has changed, and I think Dr. Mongiu really did a great job at showing you, some different applications of technology about how we see the disease and how we're able to do better by seeing better using these technological advances. But I thought I would talk a little bit about not only our view of the technology and how we improved each individual patient, but how we improve the care of our patients as a whole, as a group. And I think, when I was a resident, one of the common sayings was from my mentors was, the surgeon is the captain of the ship. And, that was sort of the mantra that we were to guide the care of the patient, and that we were the captain. And I think viewpoint has largely changed about that. And that I think now we really view what we do as a team effort. And so instead of, how do surgeons care for colorectal cancer patients, it's largely become, how do we care, with the emphasis on we. It's a team-based approach to colorectal cancer care. And I think that's really, to me, the greatest innovation over the last, many years, is how integrated the delivery of our care is for cancer patients. And it's a journey that has many team members impacting the care journey along the way. And it becomes an integrated pathway of multiple different specialties and also non-clinical support. And, I love this quote from Michael Jordan, and, talent wins games. But teamwork and intelligence wins championships. And that's the same idea when we talk about taking care of rectal cancer and colon cancer and anal cancer, is that, individual outcomes are wonderful. Individual talent is great. We have incredibly talented surgeons and oncologists and radiation oncologists and other caregivers that bring incredible specialty experience to the table. But we do so much better when we integrate all that care into a team-based approach. And so how do we do that in real time with individual patients? Well, we have brought together incredible talent in terms of our specialists, and we work to coordinate that care. We use digital platforms so that we can not only communicate between providers, but also with patients, so that access is an incredibly important thing that our patients have, and they're not leaving a message and not getting calls back. All those calls are documented, and we have support education that we can provide those patients using internet platforms, whether that's through the EMR like Epic, which we use here at Yale, but also other platforms. We've employed a lot of advanced clinical support staff, and that includes physician assistants, highly specialized nurse practitioners, and other support staff that really provide a ton of clinical support to our patients as they're going through a really difficult time in their lives. We also then focus on, trying to bring all the care to be centered around patients. Rather than patients running to different sites for tests and labs and imaging, we try to bring all of that to the patient at a single site. And that includes genetic counseling, that includes support groups, that also includes an incredible integrated patient-centered support system that includes massage therapy, Tai Chi, acupuncture, all centered at the Trumbull location. And I think, all of those things together, including the meditation garden that we have in the center of our Trumbull location, which I have to admit, I've sat in front of that waterfall a couple times on a couple hard days. So I can tell you, I've found peace there. And I know that many of our patients really enjoy that part of their care journey, that it's a place of support. And then we talk about, well, how do we improve quality and how do we drive improvements in the delivery of what we're doing? And I can tell you that it happens both at the hospital level and it also happens as an entire system. So when we talk about, say, Bridgeport Hospital, New Haven Hospital, or Greenwich Hospital, we're looking at the data to see how we're doing. And we're taking that data and then comparing that to the standards that are being set nationally, and also that are internal standards to try to achieve as a health system to truly be world-class, which is our goal. We have lots of groups where we work together. We're actually, colon and rectal surgeons or surgeons who do colon and rectal surgery come together and we kind of talk about our best practices and how we can improve, and we coach each other in a very collegial manner. We use tumor boards. We focus on building standardized systems that will apply to all of our hospitals and every patient that comes through our system to maximize their outcomes. We also use different innovative approaches that are being done at different parts of our health system, and then we integrate them into the practice at various delivery networks, whether that's in the Bridgeport region, the Fairfield region, New Haven, or other markets. And I think the other thing that's really wonderful about having a team-based approach to colorectal cancer is that we can approach challenging low volume cases. So that's recurrent colon cancer, recurrent rectal cancer, specialized recurrent anal cancer. So we're able to manage very complex situations because we just have a big team and a lot of infrastructure and a lot of depth to the talent and the types of technology that we have here at Yale. We're very lucky that we can serve that population of patients. And then the last thing I would say is that, we've tried to build programs out into the communities of where our patients live. And so that we're more accessible to our patients, and certainly patients that travel during their cancer care, it's a major barrier. And so we want to lower those barriers to as low as possible so that we can make directed appointments in where patients live and in their communities, and also bring specialists all around the patient so that we can deliver multidisciplinary care, not just your surgeon, but your oncologist, your radiologist, your pathologist, all coming to you around the same center. And you're going to meet Dr. Persico and Dr. Du, who I work very closely with. And then obviously keeping in communication with our patients' primary care doctors, their gastroenterologists, and making sure that they are looped in on what we're doing. And most importantly, I think that the biggest innovation, has been our ability to come together as a team of providers to be centered around our patients, whether it's our rectal cancer multidisciplinary program, which you'll hear about, which is one of the only ones in the Yale New Haven Health System. And we're extremely excited to be able to offer these types of services to our patients in the community. And that's really all I have to say. And thank you again for the opportunity to be here tonight, and just very privileged to be around so many great providers tonight. So thank you so much.
Thank you, Amit. Thank you, Anne. Those were both fantastic talks. I just want to encourage, if anyone in the audience has any questions that they wanted to direct towards any of the panelists, just do it either through the chat or through the Q&A. I thought I would just take 2 minutes just to ask a question. One of the most feared outcomes of surgery for colorectal cancer is the need for an ostomy. And I was hoping you could answer one, how you make that decision of who needs one, and then as importantly, what's the support that's given to a patient who needs an ostomy during either before surgery, after surgery, to help reduce some of that anxiety?
I can speak a little bit to that. And certainly, discussion of a stoma really is one of those points of high stress. So at one of the things that we do have are what we call wound ostomy care nurses. And what's one of the really good strengths of our entire system? We have preoperative coaching, marking, counseling, and nutrition available actually through our office, in our outpatient office at Dana 2. And I know that there's a whole set of at Bridgeport again, and throughout actually the Yale system, all the hospitals have in and outpatient wound ostomy supports. So they do a lot of the teaching. And so there's support in the hospital, before the hospital, after the hospital. And if we have a stoma and a new stoma in a patient, we send patients home with a visiting nurse. So from a physical support side, we have nursing staff and education pre and post-operatively in place. But the real question is, who needs a stoma or who gets a stoma? And maybe more importantly, is that stoma going to be permanent? In this day and age, really, there's very few cancers that we make a permanent stoma for. And those are sometimes rectal cancers that are so low that they're invading the sphincter complex. And so in which case we can't actually spare it, and the stoma that we would create would actually be permanent. That's one of the few situations where I can tell you up front, we do use a permanent stoma. Most of the other surgeries we do sometimes will require a temporary stoma, and that's oftentimes in rectal cancer surgery when we're operating what we call a low anterior resection or lower in the pelvis. And in that case, if someone has received upfront chemotherapy and radiation, the risk of that, basically, for lack of a better word, the plumbing, where we put the two ends together, the risk of that not healing perfectly in the face of radiation and chemotherapy before surgery is a little higher there. And so oftentimes we do give patients a temporary stoma. And in my practice, temporary means 4 to 6 weeks. Usually 3 to 4 weeks after surgery, we do a radiology study to make sure that the hookup is watertight, at which point in time we close the stoma shortly thereafter. Sometimes in emergency surgeries or in very frail patients who are having, who've come in with an emergency perforation from their cancer, those are cases where we might sometimes have to also give a stoma, even though it's not a rectal cancer. But those usually with time and recovery and treatment can recover, and we can usually close those stomas down the line at the appropriate time. Amit?
Well, I don't know how much I can add to that. I think Dr. Mongiu did a great job of talking about that. I guess the only thing I would say in support of Dr. Mongiu's comments is that, I think the way we view taking care of our colorectal cancer patients is a journey and a relationship, not a transaction. And I think that's critical, so that we've built into the process of how we take care of our patients that ostomy support is baked in. So for example, in a practical way, what does that mean? Well, if a patient comes to us with a very, very low rectal cancer, which means the rectal cancer is invading the muscles right at the bottom, right near the anal canal, and we know we have to make an ostomy for that patient, we're going to do a lot of things for that patient that are not just involved with doing the surgery to remove it, but rather teaching that patient when they come in before they have the surgery, helping them work with other patients and connecting them to other patients who've gone through similar situations, to counsel them on how they're going to adjust, and then support them post-operatively with hooking them into various ostomy support teams. And we have some of the best ostomy nurses. I don't know if there's an ostomy competition for ostomy pre-op education and nursing, but I know we'd win, or we would be super competitive, because we have just an incredible team, and we're very lucky that our patients have access to them. And then also every patient that comes to us post-operatively, whether they have a temporary ostomy or a permanent one, they're going to get refitted. So as my body no longer fits into my wedding suit, folks who have their ostomy changes over time. And so we have to provide that support for our patients lifelong.
Thank you. All right, let's in that vein, I think this is a good time to bring in a discussion about radiation. And so Dr. Kevin Dew is here from radiation oncology. Thank you.
Myself, hello. Great. Can folks give me a thumbs up if they can see my screen? Perfect. So I think this is actually a really nice place to talk about radiation, as a lot of times when we talk about radiation for colorectal cancers, we are talking about working together as a team, and especially with the surgeons and trying to enhance the surgical outcomes. So the thing that I really enjoy about radiation, about GI oncology, is that we are an inherently collaborative effort, and I think what folks have said about working as a team is one of my favorite parts about treating colorectal cancers and taking care of patients together with such a phenomenal team. The first thing I think to talk about is really the question of what is radiation oncology, and I think intuitively, most everyone will know what gastroenterologists do, what surgeons do. Even medical oncology, I think, is pretty much folks will know about chemotherapy. But radiation oncology, because not many colorectal cancer patients will actually encounter radiation treatments, is a little bit of a question. And so I thought I would take a minute to talk about what is radiation oncology, and then how do we use it in colorectal cancers to help patients. So let me see. Okay, so in terms of the history of radiation oncology, it's worthwhile noting that we've actually been using radiation to treat cancers almost since the phenomena of radiation was first discovered in the 1800s. So this is a picture of the first X-ray taken. Wilhelm Röntgen, who discovered the mysterious X-rays, actually took a picture of his wife's hand, and this is actually her wedding band there, very famous historical picture. This really transformed and revolutionized cancer care. Before this, there was no way to see inside a patient and detect cancers other than surgery, other than opening up a patient. And so this really was an incredible step forward. And almost immediately, not only were we able to see cancers inside patients, but within a few months of the discovery of the phenomena of radiation, we were actually using radiation to treat cancer patients. And the first cancer patient was treated in 1896 in Chicago who had a recurrent inoperable breast cancer. The golden age of radiation oncology came about in the 1950s at Stanford with Henry Kaplan and Saul Rosenberg using, Henry Kaplan was one of our first machines that we used to deliver radiation. And Saul Rosenberg, really a chemotherapy giant, and using combination chemotherapy and radiation to provide the first non-surgical cures of cancer. And this is really a phenomenal step forward, and really led to, over the next few decades from the 50s till now, an explosion of cancer treatment options and really innovations in curing patients. So right now, modern radiation therapy moving into 2022 is really based on all the advances in physics that have happened over the past few decades, all the huge advances in biology, and understanding how radiation interacts with cancer. And then really, as I think Dr. Mongiu was saying something about iPhones, advances in technology over the past few decades. Also, all such that, this is one of our modern radiation machines, which has a lot of bells and whistles, which we can use to really personalize patient care and cancer treatments in a very patient-centric way, even though we are talking about, this black box of radiation. So for colorectal cancers, I couldn't have had a better introduction into why we use radiation for colorectal cancers than from Dr. Khanna and Dr. Manchu, who have a keen appreciation of the role of radiation for colorectal cancers. But the reason why we use radiation in colorectal cancers is that for most colon cancers, we do not need to use radiation, and that's a good thing. But as we get further down to the end of the colon, we enter this part of the bowel called the rectum, And that rectum, as has already been discussed, is right here at the bottom of the pelvic bowl. And as you get farther down, deeper into the pelvis, the space here gets narrower. There's all these muscles here that control things like continence. And, I think the idea of a colostomy has already been brought up. If you cut too close to these muscles, or the tumor is invading into those muscles. And that's really where radiation can help, because that we can give radiation before surgery in order to reduce the tumor size, to get the tumor to pull away from these muscles, to pull away from the pelvic sidewall. And by doing this, we can improve surgical outcomes and decrease the risk that the cancer comes back even after a successful surgery. In addition, we can even get the cancer to shrink away from these muscles that control continence, and allow surgeons to potentially preserve more of those muscles, and decrease the risk of having patients have a permanent colostomy after surgery. So in addition, as I think was mentioned as well in Dr. Shahar's case, for patients who may not be in the best health, who may not be candidates for these big surgeries, that we may actually use chemotherapy and radiation instead of surgery for patients who may not be medically able to handle surgery. So as I alluded to, all these advances in technology and how we think about using radiation for cancer treatments really is a early example, as I said, going back 100 years of how we personalize care for patients. And nowadays we talk about a lot about personalized care, but in radiation, we've been personalizing care for many, many years now. One of the main way that we do is in a measured way that we decide what to treat with radiation, what we decide, how we aim the radiation. And everybody's different and everybody's body is different. And we can actually consciously these days, with all the technology, figure out precisely how to aim the radiation. This is an example of a radiation plan where we're looking at a CT scan through a patient's body. And here you can see the leg bones here attached to the hip bones. This is the front of the patient, this is the back of the patient. And back here is the rectum. The red and the blue are the radiation doses that we're targeting to the rectum, as well as to the lymph nodes around the rectum. This is a side view where this is the spine, the curve of the back, and the tailbone, as we're looking at the patient to the side in a CT scan. And what you can see is we can actually aim radiation at the rectum, at the lymph nodes, and actually spare this middle part where this is bowel. So we can actually spare non-involved bowel, and you can see that over here as well in the front. We can spare non-involved bowel from radiation exposure, treating only what we need to do, reducing the side effects of diarrhea and things like that from radiation exposure of the bowel. Another very simple trick that we can use during radiation treatment is positioning. So everybody, again, is different. Sometimes we can actually very simply just lay a patient down on their stomachs on the treatment table. A patient's head would go here, and there's an opening here where patient's stomachs fall through this hole. And you can see that on this CT scan where, again, looking at the side of the patient with the rectum here, that the bowel actually can fall out of the pelvis forward into this opening here, and really spatially put quite a bit of distance between where we're aiming, the rectum, and then the small bowel, which causes a lot of the side effects of radiation. And so, again, a way that we can use anatomy, positioning, and technology to reduce the side effects of radiation and make radiation safer while maintaining the effectiveness. And then the final way that I'd like to talk about in terms of using radiation is really for folks, regardless of if they have colon cancers or rectal cancers, if the cancer is spread to other parts of the body. I think this is something where there's so many treatment options for colorectal cancers these days across all stages of cancer, that even if cancers have spread to other parts of the body, I do think there's still a really good measure of hope and many, many treatment options for them. And Dr. Kortmansky will talk more about that. But these days, people are living longer and longer with cancer. We're curing more patients with cancer. But for patients who have cancer that's spread to other parts of the body, we actually think that they can live for many, many years at this point. And one of the tools in our toolbox that we have to treat metastatic deposits is radiation. Using radiation here, again, in the colored lines, to treat spots of cancer that have spread to the liver or spots that have spread to the lungs, in order to, in a non-invasive way, ablate these tumors and improve disease control in these patients. So these are just some examples, again, of how we use radiation therapy in a very tailored way. And a lot of that is really in talking to the patients, trying to figure out what their priorities are, what their hopes are, and what patients really want out of their treatment. And it is not a one-size-fits-all treatment. And as Dr. Khanna has really emphasized and described very well, it's a team approach. And it's not just me as the radiation oncologist sitting there talking to you. It's all of us talking to you and sharing our thoughts and trying to understand the patient. So I'll finish up there and turn it back to Dr. Kortmansky.
Thank you, Kevin. That was a great talk. I had a question that we often get asked, which is why radiation takes so long to finish, and whether there are any options to do it in a shorter way.
I thought you said to keep this talk to a short. So I think a lot of that is historical, in all honesty. So at the beginning, you remember I said in the 1800s when radiation was discovered. You can imagine that when you're talking about unregulated sort of radiation, when you don't really understand too much about radiation, that the toxicities can actually be substantial. And so in order to make radiation more tolerable, in the 40s, 50s, this movement happened in radiation, which said that we can actually cure the same number of patients, but it makes radiation safer and more tolerable if we give it in small doses over many weeks. This so-called fractionation of radiation was really one of the biggest advances in the last century. As technology has improved, we can actually it's kind of a back to the future sort of thing, where we can now, because of the way we deliver radiation better, we can actually go backwards. We can actually deliver higher doses of radiation in shorter courses safely. So we're starting to gradually move back to shorter courses of radiation. But a lot of the history of radiation is with extended courses of radiation, and we're working on it, though. We're trying to make radiation more convenient and safer for our patients.
Perfect. Thank you. All right, and so we'll get to the medical oncology part. Dr. Justin Persico is with us to talk about advances in treatment.
Thanks, Jeremy. I'm going to get my screen up here. Okay, coming up. So I first want to thank all my colleagues all there so far. Really enjoyed it. I really like how you've all driven home the idea of a team-based approach to colorectal cancer care. And my job as part of that team is as the medical doctor, giving any of the medicines, as well as doing a lot of the surveillance, the follow-up, the monitoring for years to come after somebody has been diagnosed and treated with cancer. And also I'm going to hit on, I think, some themes that my colleagues have been hitting on here, which is that we are all engaged in an effort to reduce the overall toxicity, side effects, improve recovery times from surgery, like you've heard about. And a significant part of what I'm going to talk about today is how we can improve on the treatments that we give as medical oncologists, chiefly chemotherapy treatment. So I'm going to pick up from where the surgeons left off and talk about, well, what happens next after the surgery when you first meet the medical oncologist? What are you there to talk about? What are you likely to hear? And I'm going to try to focus on some of the key points of the presentation in the interest of time. I'm not going to go over some of the anatomy as you see in the picture here, but I'll just mention, a little bit about the background of colorectal cancer and the burden of
we
this
can't
disease.
see your slides.
Did something? Were you able to see them initially, or?
Yeah.
Yeah, it looked like it stopped sharing for some reason. Try this again. All right, are you able to see it?
Yeah, perfect.
Okay, great. So there's approximately 150 new diagnoses of colorectal cancer each year in the US, of which about 70% of them are involving the colon and 30% involving the rectum. And I have the picture here just to remind everybody about the different parts there of the colon. My focus for today is really going to be talking about colon cancer, and in particular stage 2 and stage 3, which I'll define for you shortly. Rectal cancer is another topic. Dr. Du alluded to some of the specifics that we think about when it comes to treating rectal cancer, but I'm going to leave that out for today. And I will point everybody that in case they do want to learn a little bit more about that this presentation from this month last year, there was an excellent presentation by Dr. Kortmansky here. So you can always find that on the website, or it's on YouTube as well. Okay, now my slide's not advancing. Sorry about the technical difficulties. Okay. Okay, so, and this, I'll just briefly mention this slide, which is just showing the improvements that we've made in treatment of colorectal cancer over the decades, and that the mortality has been decreasing significantly, both because of better treatments, but I think primarily because of better screening. The top two lines here, you'll see the incidence, or the number of cases of colorectal cancer that we see, and how that's declined significantly, primarily now because of screening techniques like colonoscopy, where these precancerous lesions can be identified before they actually become cancer. So another plug for screening here. And one of the first things you'll talk about with the medical oncologist is the stage of the cancer, because this really determines for us how we should approach the next steps after surgery. And the way we stage cancer is using what's called the TNM system, or tumor nodal metastasis system. And I have a picture here sort of explaining how we separate the different T stages, or tumor stages, showing a picture of the colon with the bowel part that's labeled as bowel being the inner part of the colon, and then the layers of the colon heading towards the outer part of the tissue. And small tumors involving just the first layer of the colon are staged as T1. And as you invade deeper and through more layers, you increase the stage, leading all the way to what we call a T4 tumor, which actually invades through the outer layer of the colon. The internodal stage is determined by the number of lymph nodes that are involved with the cancer. So when you have your surgery, the surgeon, as explained by the surgeons, it removes the section of colon that's involved with the cancer, and along with that, the blood vessels and the lymph nodes that are all associated with that section. And all of that is taken to the lab and analyzed under the microscope. And if any lymph nodes are involved, those are counted as part of the pathology. The M stage, referring to metastases, basically means if we see cancer in any other parts of the body, for example, the liver or the lung, as Dr. Du had shown. This is typically known in this situation before having surgery. You would typically have some forms of imaging, CAT scan or MRI, that would be there to look for any evidence of the cancer having already spread, because that might change the overall treatment strategy approach. We use that information to group the patients into different stages. Here I have outlined that stage 1 tumors in general are tumors that are not invading very deeply and have no lymph nodes involved. And the approach to those cancers is typically just observation. They have, thankfully, a low risk of recurrence. They have a high rate of being cured with surgery alone. So we just monitor those patients. Stage 2 tumors invade more deeply into the colon, but still have no lymph nodes. And this is where there's a little bit more difficulty in determining the optimum strategy, because we understand that there is a higher risk of recurrence, and a lot of the efforts are trying to that we're doing right now are trying to identify who are those patients within stage 2 that are at the highest risk, and potentially offer them treatment to try to reduce that risk. Stage 3 cancers now involve lymph nodes, and that is concerning because that is the first time or first behavior of a cancer starting to spread throughout the body. And the hope is that we can stop it at that point before it does spread to distant sites within the body. And in this case, there is a much higher risk, and therefore additional treatment after surgery is recommended. Stage 4 cancer means that the cancer has already involved other organs, and that's another topic that could be talked about on its own. So we're going to skip over that for today. So why would we consider more treatment, specifically chemotherapy? Well, this graph shows some of the risks that are associated with the diagnosis of colon cancer. As I mentioned, stage 1 cancers thankfully have a low risk, the orange bar indicating what is the risk of this cancer coming back within the next 5 years or so. And because the risk is low, there's not really much we can do to improve on that. And so observation is just recommended. But as you go up in stage from stage 2 to stage 3, that risk significantly climbs, with the average patient having a stage 3 cancer having about a 50% chance of their cancer recurring. So we'd like to do something if we can to reduce that chance and increase those patients' chances of being cured. So when it comes to the stage 2 tumors, it's a bit more questionable how we decide who is at the higher risk within that group and who might benefit from additional treatment. The traditional way we look at this is by actually looking at the features of the cancer when those samples that are removed from the surgery are analyzed in the lab. And there are certain high-risk features that might make us think that somebody's at a high enough risk that they would benefit from additional treatment. There are now also more sophisticated ways to help us determine this risk. Some of the first ideas that were developed were to look at the genome within the cancer, and specifically at genes that are known to predict a higher risk of the cancer having bad behavior and potentially coming back. I've listed some of the available tests here. And so sometimes this test might be ordered by your oncologist to help him or her with a decision about whether to offer chemotherapy. The sort of new frontier that there's a lot of interest in is looking at whether or not we can detect the presence of tumor DNA in your blood. People who have tumor DNA detected in their blood are felt to be at a higher risk for their cancer recurring, and maybe the patients who are best served by getting adjuvant chemotherapy if they have stage 2 disease. And I'm going to talk about a little bit later on about clinical trials that are looking at this. This is not yet the standard of care, but appears to be on the cusp of becoming the standard of care. And I'm not going to go into this in the sake of time, but I had a link down here I was thinking of showing everybody. But basically, there are also these nomograms or calculators that we can use as medical oncologists, where we can input information about the patient and the patient's cancer to come up with a risk score to help us guide our treatment decisions. There's actually something that's available for patients to access as well, so they can also go along through this with their oncologists. And I've done this with many patients in the past to help us with our decisions. So when somebody does need chemotherapy, what are the drugs that we use? Well, the mainstay and the backbone of treatment are a class of drugs which we call fluoropyrimidines. And it comes in both intravenous and oral forms. In the US, we primarily use these two forms, the intravenous being called 5-fluorouracil or 5-FU, and the oral form being called capecitabine, or the brand name is Xeloda. Commonly, the intravenous form of these drugs is combined with something called leucovorin, which is not a chemotherapy drug, but actually an adjunct. It's actually a form of folic acid that helps the drug better target its target enzyme, which is what actually kills the cancer cells. So it improves the efficacy with adding little to no increased toxicity. The other drug that is commonly used is something called oxaliplatin, or aloxatin is the brand name. And this is a drug that can add a little bit more to the backbone of the fluoropyrimidine. And for patients who are at the highest risk, the combination has been shown to be better in terms of helping them have a higher chance of being cured. And when we combine these drugs, we use the following acronyms that you may hear when you talk with your medical oncologist. When you combine the 5-FU and the oxaliplatin, we call that regimen FOLFOX. And when you combine the capecitabine and the oxaliplatin, we call that regimen CAPOX, or you sometimes might hear a Zelox if they use the brand name Xeloda. So what are the benefits of chemotherapy and what are the potential downsides or adverse effects? Well, the benefit, as has been shown in multiple clinical trials, is that it reduces the risk of cancer coming back by about 30 to 35%. So that's increasing your chance of being cured of the cancer. But unfortunately, chemotherapy is associated with some significant side effects. And this list I've listed here is by no means inclusive, but are some of the more common effects that we see. I'll highlight a couple. In particular, I would say fatigue is by far the most common effect of chemotherapy. And the peripheral neuropathy, which is an effect on the nerves that are in the periphery of our bodies and our fingers and toes, can be very problematic, and one of the potential side effects that we can that may result in treatment changes or limit the amount of treatment. Most of these are monitored or all of these, I should say, are monitored very closely and can be managed. There are rare, more severe side effects listed here, but we also monitor very closely for those to make treatment as safe as possible. However, we're always looking to see how can we improve the toxicity of treatment. And I would say the number one thing that we do is by maximizing our supportive care. So these are medicines that we might give you or use to help prevent or reduce the side effects, as well as support services that we have to help as well. For example, if somebody really is struggling with appetite during treatment, then we have dietitians that work with us that can become involved and to help make sure the patient is getting the appropriate nutritional support through their treatment. There's also always dose adjustments that can be made. Chemotherapy is typically tailored individually to the patient. We use variables such as the patient's height and weight and laboratory results to adjust their dose, even sometimes treatment to treatment. But sometimes we don't get it exactly right, and we have to make an adjustment, either lowering the dose or altering the schedule of the treatment. The other goal is to use the minimum treatment necessary. Now that should be self-explanatory, but a lot of like what Dr. Du had just mentioned, a lot of the treatments, doses, and amount of treatment we give are somewhat historical. And with more study over time, we found that maybe we can adjust or reduce the amount of treatment and still get the same effects. So when we look at whether or not we can reduce chemotherapy, there are some studies that can help inform us on this decision. So initially, some big clinical trials set the standard that we would give 6 months of chemotherapy for patients who are at the highest risk of recurrence. And this is what had been done for many years. However, analysis of more and more data coming from multiple trials looking at the treatment of colon cancer has called some of this into question. And in particular, this IDEA group collaboration looked at this fairly recently and challenged whether 6 months should be the standard of care for all patients. What they did is they looked at patients and stratified them into low and high risk groups to see if there was a difference and whether outcomes were just as good with less treatment as with more treatment. They also looked at the impact of the intensity of the treatment, how many doses were given, for example. And they also looked at whether there are differences based on the age of the patient, in particular older patients over the age of 70. in these studies, they defined low-risk patients as those who have 3 or fewer lymph nodes involved with their cancer, no evidence that their cancer had perforated the colon or caused an obstruction, and no advanced tumors invading through that outer layer of the colon, as I mentioned before. And in those patients, they found that 3 months of the regimen with capecitabine and oxaliplatin had the same efficacy as 6 months, making 3 months the new standard of care for those patients. This, interestingly, was not true for a regimen that used fluorouracil with the oxaliplatin. It's not entirely clear why there was a small difference there, but for now, the capecitabine-based regimen is the regimen of choice for people who are eligible for a 3-month treatment rather than a 6-month treatment. Now, in patients who are older, over 70, there's been some study on this already before, and in this database, it was also not entirely clear that there was any difference between younger and older patients. However, the trends overall are that the likely benefit to combination chemotherapy may be small, and that the risk of toxicity is increased in older patients. So this is something that really needs to be an individualized discussion between the oncologist and the patient, and takes into account multiple factors, specifically the patient's performance status, how functional they are, what other medical comorbidities or other medical diseases that they have. The other thing they looked at here is specifically the drug oxaliplatin. And when they looked at patients who were planning to receive 6 months of chemotherapy, but had to have their doses of their oxaliplatin stopped or reduced because of toxicity, if they received at least 50% of the doses, they had the same outcomes as those who received all the doses over 6 months. So this led to the thought that perhaps this drug, at least the oxaliplatin, could be reduced as part of this treatment. And why does this matter? Well, in particular, reducing the oxaliplatin has been shown to cut the overall risk of significant adverse effects by 1/3 to 1/2. So it would be very helpful if we could reduce it. Oxaliplatin is the drug that causes that peripheral neuropathy symptom I mentioned, and it can lead to permanent neurologic effects, including functional issues related to this. The risk of, to show you the difference, the risk of peripheral neuropathy with only 3 months of the drug was only about 10%, whereas if you were to get a full 6 months, that risk goes up to 30%. This is the best data we've had so far, and it's certainly provocative and I think becoming incorporated more and more into practice, but there may be individual reasons for each patient that they should discuss with their oncologist why treatment may not be recommended to be reduced in their particular case. So in summary, patients with low-risk colon cancers can be treated with 3 months of chemotherapy instead of 6. Patients who are older should discuss with their oncologist and be counseled about the risk versus benefit of using combination chemotherapy rather than just using one of the fluoropyrimidine drugs alone. Patients who experience neuropathy during their treatment may not derive much benefit from more than 3 months of the oxaliplatin drug. And so it appears that it is safe and does not affect outcomes if we have to stop that drug early due to the risk of worsening neurotoxicity. And patients who tolerate the oxaliplatin perhaps should continue until we have more confirmation and more data on this on an individualized basis. The risk really should be discussed between you and your oncologist and individualized to your particular case. So I wanted to just take a minute to talk about some future directions and give a plug for our clinical research efforts, which at Yale we have a very robust clinical trial portfolio and always trying to advance the field. The first 2 studies I want to talk about here are ones that are available here at Yale for our patients. And one of the ways we're looking to improve the chances of patients being cured of their colorectal cancer is by adding immunotherapy to their treatments. This is a very hot topic and is a real breakthrough in the treatment of cancer in general. And in particular, in colon cancer, it appears to be highly effective for patients that have what is called Lynch syndrome, which is a deficiency in DNA repair. So we have ongoing trials looking at adding these drugs to see if we can increase their chances of being cured. We also have trials looking at the use of the circulating tumor DNA testing that I mentioned before, using that to help stratify the risk for patients who have stage 2 colon cancer, where, as I mentioned, there's a bit more ambiguity about who may benefit and who may not benefit from chemotherapy. In other centers, they're looking at things like adding a third drug to the chemotherapy regimen. So this is in particular may be helpful for higher risk patients. And there's also trials looking at adjuvant cancer vaccine therapy, another form of immunotherapy, again, trying to reduce recurrences and improve chances of being cured. So I think I'll finish there. And I thank you all for your attention. I'd be happy to answer questions and look forward to the discussion.
All right. Thank you, Justin. That was great. I think we've gone a long time tonight. I think it's clear that all of our panelists are very enthusiastic about what they do and how we can help patients with colorectal cancers. I don't see any questions in the Q&A or the chat, and so I think I'll take this opportunity to say that there is a lot that we can do to treat cancer and cure cancer, but still the best thing we can do is prevent it from happening in the first place. And so I would say that not only includes all of the various ways that we can screen for colon cancer with, as Dr. Sachar outlined at the very beginning, but also by taking good care of ourselves and focusing on a healthy lifestyle that includes exercise, a diet that is full of fruits and vegetables, reducing alcohol intake, and reducing stress. And those are practical things that all of us, even those of us on the panel, that probably can do a better job of every day. So I'd like to thank all of our panelists for joining us tonight. I'd like to thank Cindy Barassi from the Colon Cancer Foundation for co-sponsoring this. And I'd like to thank everybody who took time out of their evening tonight to join us and learn a little bit more about this disease and hopefully spread the word. So thank you and have a great night.
Thanks, everyone.